When a newborn is born, they must make a rapid transition from life inside the uterus to life outside the uterus, known as adjustment to extratrauterine life. This transition requires major changes in the respiratory, cardiovascular, thermoregulatory, gastrointestinal, and immune systems. How well a newborn adapts depends on several factors. One important factor is the infant's genetic background. Genetic traits can influence growth, development, metabolism, and susceptibility to certain health conditions. Some newborns may have inherited conditions that affect their ability to adapt to life outside the uterus. Another factor is the health of the intrauterine environment during pregnancy. A healthy pregnancy with adequate maternal nutrition, oxygenation, and prenatal care supports fetal growth and development. Conditions such as maternal hypertension, diabetes, infections, substance use, or placental problems can negatively affect fetal well-being and the newborn's ability to transition successfully. A safe delivery is also critical. Birth complications such as prolonged labor, fetal distress, birth trauma, or oxygen deprivation can make the transition more difficult. Prompt recognition and intervention by the healthcare team help reduce risks and support newborn adaptation. The care received during the first month of life, often called the neonatal period, has a significant impact on long-term health. During this time, newborns require adequate nutrition, warmth, infection prevention, safety measures, and ongoing assessment to ensure healthy growth and development. Another important concept is the relationship between maternal and newborn microbiomes. The microbiome refers to the collection of beneficial microorganisms that live on and within the body. During vaginal birth, newborns are exposed to maternal bacteria that begin colonizing the infant's skin and gastrointestinal tract. These microorganisms play an important role in immune system development and overall health. The newborn's gut microbiome is further supported by breastfeeding. Human milk contains beneficial bacteria, antibodies, and prebiotics that encourage the growth of healthy intestinal microorganisms. A healthy gut microbiome helps support digestion, immune function, and protection against infections. As nurses, understanding the factors that influence adjustment to extrauterine life helps us recognize newborns who may be at risk for complications and guides us in providing safe, evidence-based care during this critical transition period. After birth, nurses perform a thorough assessment of the newborn to identify expected findings, recognize variations of normal, and detect abnormal findings that require further evaluation or immediate reporting to the healthcare provider. Newborn assessment is ongoing and helps ensure the infant is adapting appropriately to extrauterine life. Understanding what is normal versus abnormal is an essential nursing responsibility. Assessment of the nervous system includes observing the newborn's level of alertness, muscle tone, posture, movement, and reflexes. Newborns should demonstrate primitive reflexes such as the Moro reflex, rooting reflex, sucking reflex, palmar grasp reflex, and Babinski reflex. Asymmetry or persistence of these reflexes beyond expected time frames may indicate neurological concerns. Evaluation of the head, eyes, and ears is another important component of the newborn assessment. Nurses assess head shape, fontanelles, and sutures, while recognizing common findings such as molding that may occur after vaginal birth. The eyes should be symmetric and free from significant drainage, and the ears should be properly positioned and formed. Low-set ears or abnormal facial features may sometimes indicate genetic or developmental conditions that require further evaluation. Sleep is essential for growth and brain development. Newborns typically sleep 14 to 17 hours per day, although sleep patterns are often irregular. Nurses educate parents about normal newborn sleep behaviors and reinforce safe sleep practices, including placing the infant on the back to sleep, using a firm sleep surface, and avoiding loose bedding and soft objects in the crib to reduce the risk of sudden infant death syndrome (SIDS). Although newborns cannot verbally communicate discomfort, they are capable of experiencing pain. Nurses assess pain using behavioral and physiologic indicators such as crying, facial expressions, changes in muscle tone, heart rate, and respiratory rate. Pain management may include non-pharmacological interventions such as swaddling, skin-to-skin contact, breastfeeding, non-nutritive sucking, and sucrose administration during minor procedures. Newborns are also capable of developing conditioned responses, which are learned responses to repeated stimuli. For example, infants may learn to associate feeding with certain sounds, sights, or caregiver interactions. These early learning experiences contribute to bonding, attachment, and neurologic development. As nurses, our goal is to perform comprehensive newborn assessments, identify findings that are expected, recognize abnormalities promptly, support family education, and promote healthy growth and development during this critical period of life. The Neonatal Behavioral Assessment Scale, NBAS, sometimes called the Brazelton Neonatal Behavioral Assessment Scale, is a specialized tool used to evaluate a newborn's neurologic functioning, behavioral responses, and ability to adapt to the environment. Unlike assessments that focus primarily on physical health, the NBAS examines how the newborn interacts with and responds to the world around them. The purpose of this assessment is to measure the newborn's inherent neurologic capacities and their responses to selected environmental stimuli. It helps healthcare providers better understand the infant's strengths, behavioral patterns, and developmental abilities. The assessment can also help identify newborns who may benefit from closer monitoring or early intervention services. One area evaluated is alertness. Newborns vary in their ability to become alert, maintain attention, and interact with caregivers. A healthy infant should demonstrate periods of quiet alertness during which they can focus on faces, voices, and other environmental stimuli. The assessment also examines the infant's response to visual and auditory stimuli. Newborns are capable of tracking faces, responding to voices, and reacting to sounds. These responses provide important information about neurologic development, vision, hearing, and sensory processing. Another area assessed is motor coordination. The examiner observes muscle tone, posture, movement patterns, reflexes, and the infant's ability to control body movements. Newborns should demonstrate coordinated movements appropriate for their gestational age, although movements are often somewhat jerky due to nervous system immaturity. The NBAS evaluates the infant's level of excitement or arousal, meaning how easily the newborn becomes stimulated and how effectively they can return to a calm state. Some infants become overstimulated easily, while others are better able to tolerate environmental stimulation. Finally, the assessment measures the newborn's organizational process in response to stress. This refers to the infant's ability to self-regulate when faced with challenges such as noise, handling, hunger, or discomfort. Newborns may demonstrate self-soothing behaviors such as sucking on their hands, grasping, or calming when held and swaddled. For nurses, understanding neonatal behavior helps promote family-centered care, supports parent-infant bonding, and guides interventions that reduce stress and encourage healthy neurologic development. Recognizing how a newborn responds to their environment allows nurses to individualize care and educate parents about their infant's unique behaviors and needs. The APGAR score is a quick, standardized assessment used to evaluate a newborn's condition immediately after birth and determine how well the infant is adapting to extrauterine life. It does not predict long-term health outcomes, but helps healthcare providers identify newborns who may require immediate support or resuscitative interventions. The APGAR assessment is typically performed at 1 minute and 5 minutes after birth. If the newborn's condition remains concerning, additional scores may be assigned at 10 minutes and beyond. Each of the 5 assessment categories is scored from 0 to 2 points, resulting in a total score ranging from 0 to 10. The first component evaluated is heart rate, which is the most important indicator of newborn well-being. A heart rate greater than 100 beats per minute receives a score of 2, a heart rate less than 100 beats per minute receives a score of 1, and absence of a heart rate receives a score of 0. The second category is respiratory effort. A newborn who is crying vigorously and breathing well receives a score of 2. Slow, irregular, or weak respirations receive a score of 1, while absence of respirations receives a score of 0. The third category is muscle tone. Healthy newborns typically demonstrate active movement and flexion of the extremities. Active movement earns a score of 2, some flexion receives a score of 1, and a limp or flaccid infant receives a score of 0. The fourth category is reflex irritability, sometimes called response to stimulation. This is evaluated by observing the newborn's response to gentle stimulation, such as suctioning the nose or rubbing the soles of the feet. A vigorous cry, cough, sneeze, or withdrawal receives a score of 2. A weak response receives a score of 1, and no response receives a score of 0. The final category is color, also known as appearance. A completely pink newborn receives a score of 2. A newborn with a pink body but bluish hands and feet, called acrocyanosis, receives a score of 1. A pale or blue infant receives a score of 0. A total APGAR score of 7 to 10 generally indicates successful adaptation to extrauterine life. Scores of 4 to 6 suggest moderate difficulty and may require supportive interventions, while scores of 0 to 3 indicate severe distress requiring immediate resuscitative efforts. A helpful way to remember the components is the acronym APGAR. A equals sign appearance color, P equals sign pulse heart rate, G equals sign grimace reflex irritability, A equals sign activity muscle tone, R equals sign respiration. As nurses, we must accurately assess and document APGAR scores, recognize signs of newborn distress, and communicate abnormal findings promptly so appropriate interventions can be initiated without delay. Maintaining normal body temperature is one of the most important aspects of newborn care. Newborns have an immature heat-regulating system, making them vulnerable to both heat loss and overheating. Newborns lose heat quickly because they have a large body surface area, thin skin, and limited fat stores. Unlike adults, they cannot effectively shiver to generate heat. Instead, they rely on brown fat metabolism, called non-shivering thermogenesis, to produce warmth. A common newborn finding is acrocyanosis, or bluish hands and feet, caused by immature peripheral circulation. This is usually normal during the first 24 to 48 hours of life, as long as the infant's lips, tongue, and trunk remain pink. Because newborns cannot adjust well to temperature changes, they depend on caregivers to maintain a warm environment. Cold stress increases oxygen and glucose consumption and can lead to hypoglycemia, hypoxia, respiratory distress, and metabolic acidosis. Nurses help prevent heat loss by drying the newborn immediately after birth, replacing wet blankets, placing a hat on the infant, encouraging skin-to-skin contact, and maintaining a warm room temperature. It is also important to understand the 4 mechanisms of heat loss: evaporation, conduction, convection, and radiation. Newborns are also at risk for overheating. Because their sweat glands are immature, they cannot cool themselves effectively. Overbundling or placing an infant in a very warm environment can result in hyperthermia. Parents should be taught to dress infants appropriately, usually in one more layer than an adult would wear, while avoiding excessive clothing or blankets. Maintaining a stable temperature helps support normal oxygenation, glucose regulation, metabolism, and overall adaptation to extrauterine life. Assessment of a newborn's pulse, respirations, and temperature provides important information about adaptation to extrauterine life. Nurses must recognize abnormal findings and report them promptly. A normal newborn heart rate is typically 110 to 160 beats per minute. A pulse rate above 160 BPM or below 110 BPM should be reported, especially if it persists. Normal respiratory rate ranges from 30 to 60 breaths per minute. Respirations above 60 or below 30 breaths per minute may indicate respiratory compromise and require further evaluation. Nurses should also monitor for signs of respiratory distress, including noisy respirations, nasal flaring, and chest retractions. These findings suggest increased work of breathing and should be reported immediately. Normal newborn temperature is approximately 36.5 degrees Celsius to 37.5 degrees Celsius, 97.7 degrees Fahrenheit to 99.5 degrees Fahrenheit. A temperature above 37.7 degrees Celsius, 99.8 degrees Fahrenheit, or below 36.2 degrees Celsius, 97.1 degrees Fahrenheit may indicate infection, environmental temperature issues, or difficulty regulating body temperature. Early recognition of abnormal vital signs allows for prompt intervention and helps prevent complications during the newborn's transition to extrauterine life. In addition to assessing vital signs and neurologic function, nurses evaluate the newborn's musculoskeletal and genitourinary systems to identify normal findings and potential abnormalities. Assessment of the musculoskeletal system includes measuring the newborn's length and weight and observing posture, movement, muscle tone, and symmetry. Average newborn weight is approximately 2,500 to 4,000 grams, 5 pounds 8 ounces to 8 pounds 13 ounces, and average length is about 48 to 53 centimeters, 19 to 21 inches. Extremities should move equally, and the infant should demonstrate good flexion and muscle tone. Assessment of the genitourinary system includes examining the genitalia and ensuring the urinary tract appears normal. The nurse should verify that the newborn voids within the first 24 hours after birth. For male newborns, the penis, urethral opening, scrotum, and testes are assessed. Both testes should be descended into the scrotum. If a circumcision is performed, the nurse monitors for bleeding, signs of infection, and adequate urination after the procedure. For female newborns, the labia, clitoris, and vaginal opening are examined. Due to maternal hormone exposure, newborn girls may have temporary labial edema, a white vaginal discharge, or a small amount of blood-tinged discharge called pseudomenstruation. These findings are normal and usually resolve without treatment. Careful assessment of these systems helps identify abnormalities early and ensures the newborn is adapting normally to life outside the uterus. Assessment of the integumentary system includes evaluating the newborn's skin color, condition, hydration, and skin turgor. The skin provides important clues about overall health and adaptation to extra-uterine life. Many newborns are covered with a fine, soft hair called lanugo. Lanugo is most commonly seen on the shoulders, back, forehead, and cheeks. It is more noticeable in preterm infants and usually disappears within the first few weeks of life. Newborns are often covered with vernix caseosa, a white creamy substance made of shed skin cells and glandular secretions. Vernix helps protect the fetal skin from prolonged exposure to amniotic fluid and provides some protection against irritation and infection after birth. Nurses should also assess for jaundice, a yellow discoloration of the skin, and sclera caused by elevated bilirubin levels. Physiologic jaundice is common and typically appears after the first 24 hours of life as the newborn breaks down excess red blood cells and the immature liver works to process bilirubin. During the skin assessment, nurses should note any unusual rashes, bruising, birthmarks, or signs of infection. Recognizing normal newborn skin findings helps differentiate expected variations from conditions that require further evaluation. Assessment of the gastrointestinal system focuses on feeding, digestion, stool patterns, and nutrient absorption. Nurses monitor how well the newborn tolerates feedings and assess for signs of gastrointestinal problems. Newborn stools change during the first few days of life. The first stool, called meconium, is thick, sticky, and dark green to black. Meconium should usually be passed within the first 24 to 48 hours after birth. As feeding becomes established, stools transition to a greenish-brown color and eventually become the typical breastfed or formula-fed stool. Constipation is uncommon in newborns but may occur if an infant is not receiving adequate intake. Nurses should assess feeding patterns, hydration status, and stool frequency. Hard, dry stools or failure to pass stool may require further evaluation. Hycos are common in newborns and are generally a normal finding. They often occur after feedings and usually do not indicate a problem. The newborn digestive system is immature at birth, but functions well enough to digest breast milk or formula. Because the stomach is small, newborns require frequent feedings. Mild spitting up can be normal, but persistent vomiting or poor feeding should be reported. Newborns have limited stores of certain vitamins, particularly vitamin K, which is necessary for blood clotting. For this reason, newborns routinely receive a vitamin K injection shortly after birth to help prevent bleeding complications. Monitoring feeding, stool patterns, and digestion helps nurses identify normal adaptation and recognize potential gastrointestinal concerns early. Preventing infection is a major priority in newborn care because the newborn's immune system is immature and not fully developed at birth. Although maternal antibodies cross the placenta during pregnancy and provide some protection, newborns are still more susceptible to infection than older children and adults. Their inflammatory response is often limited, meaning they may not show obvious signs of illness until the infection becomes more serious. Newborns are particularly vulnerable because their skin and mucous membranes are still developing and serve as less effective barriers against microorganisms. In addition, procedures such as heel sticks, injections, or circumcision create potential entry points for pathogens. The umbilical cord stump is one of the most common sites for newborn infection. After birth, the cord begins to dry, shrivel, and separate. During this process, bacteria can enter the body if the area is not kept clean and dry. Parents should fold the diaper below the cord stump to prevent irritation and avoid covering it with tight clothing. Signs of infection that should be reported include redness extending onto the abdomen, swelling, warmth, foul odor, purulent drainage, or bleeding. Hand hygiene remains the single most effective way to prevent infection. Nurses, parents, family members, and visitors should wash their hands before touching the newborn. Proper hand hygiene is especially important after diaper changes, using the restroom, handling pets, or caring for someone who is ill. Nurses should also teach parents to limit exposure to individuals who are sick. Because newborns have limited immunity, illnesses that may seem minor in adults can become serious in infants. Visitors with symptoms such as cough, fever, vomiting, or diarrhea should avoid contact with the newborn. Another important preventive measure is the administration of erythromycin ophthalmic ointment shortly after birth. This medication helps prevent neonatal eye infections that can occur from exposure to organisms such as Neisseria gonorrhoeae or Chlamydia trachomatis during delivery. Breastfeeding also plays an important role in infection prevention. Breast milk contains immunoglobulin A, IgA, white blood cells, enzymes, and other protective factors that help protect the infant against gastrointestinal, respiratory, and ear infections. Unlike adults, newborns often do not develop a high fever when infected. Instead, signs of infection may include temperature instability, poor feeding, lethargy, irritability, respiratory distress, apnea, jaundice, vomiting, or changes in activity level. Because these signs can be subtle, nurses and parents must remain vigilant. As nurses, our role is to protect the newborn through strict infection control practices, parent education, proper cord care, administration of prophylactic medications, and early recognition of abnormal findings. Early detection and prevention are essential because newborn infections can progress rapidly and become life-threatening if left untreated. Discharge planning begins when the laboring patient is admitted, not on the day of discharge. Early teaching allows parents time to learn, ask questions, practice skills, and gain confidence in caring for their newborn at home. One major focus is basic infant care. Parents should learn how to feed, bathe, diaper, dress, comfort, and safely handle their newborn. Education should also include normal newborn behaviors such as feeding frequency, sleep patterns, stool changes, and crying. Safety measures are another essential topic. Parents should be taught safe sleep practices, including placing the infant on their back to sleep, using a firm sleep surface, and keeping blankets, pillows, and stuffed animals out of the crib to reduce the risk of sudden infant death syndrome (SIDS). Teaching should also include information about immunizations. Parents should understand the importance of the recommended vaccination schedule and know that the hepatitis B vaccine is commonly administered shortly after birth. Before discharge, families should be aware of the importance of attending all follow-up appointments. These visits allow healthcare providers to monitor growth, feeding, weight gain, jaundice, and overall health. Proper car seat safety must be reviewed and demonstrated. The newborn should travel in a rear-facing car seat that is correctly installed and secured according to manufacturer guidelines. Parents should also know the warning signs that require medical attention, including fever, poor feeding, lethargy, difficulty breathing, persistent vomiting, decreased wet diapers, worsening jaundice, or signs of infection around the umbilical cord or circumcision site. Finally, families should leave the hospital knowing who to contact and when to seek help if concerns arise. Effective discharge teaching promotes safe newborn care, reduces preventable complications, and helps parents feel prepared for the transition home. A preterm newborn is an infant born before 37 completed weeks of gestation. Because many body systems are not fully developed, preterm infants face increased risks for complications during the newborn period and throughout infancy. Preterm birth is the leading cause of infant mortality during the first year of life. The earlier a baby is born, the greater the risk for serious complications involving the respiratory, cardiovascular, neurologic, gastrointestinal, and immune systems. Preterm infants also have a higher incidence of congenital anomalies and birth defects than full-term infants. In addition, developmental delays and long-term health challenges are more common among infants born prematurely. In general, the lower the gestational age and birth weight, the greater the risk for complications during delivery and immediately after birth. Extremely low birth weight infants often require intensive support in the neonatal intensive care unit (NICU). Common complications of prematurity include respiratory distress syndrome, difficulty maintaining body temperature, feeding intolerance, hypoglycemia, infection, jaundice, apnea, and intraventricular hemorrhage. These infants often have limited fat stores, immature lungs, and an underdeveloped immune system. Nurses play an important role in caring for preterm newborns by monitoring respiratory status, maintaining a neutral thermal environment, supporting nutrition and growth, preventing infection, and promoting family bonding. Parents may experience significant stress and anxiety, making education and emotional support essential components of nursing care. The key concept to remember is that the smaller and more premature the infant, the greater the need for specialized monitoring and interventions to support survival and healthy development. Gestational age refers to the length of time the fetus remains in the uterus before birth. Determining gestational age is important because it helps healthcare providers anticipate the newborn's developmental maturity, potential complications, and care needs. A preterm infant is born before 37 completed weeks of gestation. Because organ systems may be immature, these infants are at increased risk for respiratory distress, feeding difficulties, temperature instability, infection, and other complications. An early term infant is born between 37 weeks, 0 days, and 38 weeks, 6 days. Although these infants are considered term, they may still have slightly higher risks for breathing problems, feeding difficulties, and jaundice compared with full-term infants. A full-term infant is born between 39 weeks, 0 days, and 40 weeks, 6 days. This is considered the optimal time for birth because the lungs, brain, and other organs have had additional time to mature. A late-term infant is born between 41 weeks, 0 days, and 41 weeks, 6 days. These infants are usually healthy but require monitoring because placental function may begin to decline as pregnancy continues beyond the due date. A postterm infant is born at 42 weeks gestation or later. Postterm infants may experience complications such as decreased amniotic fluid, placental insufficiency, hypoglycemia, meconium aspiration, and birth injuries related to larger size. Understanding gestational age helps nurses anticipate normal findings, recognize potential complications, and provide appropriate care based on the newborn's level of maturity. The closer an infant is to 39 to 40 weeks gestation, the more likely they are to have fully developed organ systems and a smoother transition to extrauterine life. Preterm birth, defined as birth before 37 completed weeks of gestation, can occur for many reasons. In some cases, the exact cause is unknown, but several risk factors are strongly associated with premature delivery. One common cause is multiple gestation, such as twins, triplets, or higher-order multiples. Multiple pregnancies place additional stress on the uterus and often result in earlier labor and delivery. Maternal illnesses can also increase the risk of preterm birth. Conditions such as diabetes, chronic hypertension, kidney disease, infections, and heart disease may affect maternal and fetal health and lead to early delivery. Certain pregnancy-related complications, such as gestational hypertension GH and preeclampsia, can reduce blood flow to the placenta and place both the patient and fetus at risk. In some situations, healthcare providers may recommend early delivery to protect the health of the patient and baby. Placental abnormalities are another major cause of preterm birth. Placenta previa, in which the placenta partially or completely covers the cervical opening, can cause significant bleeding and may require early delivery. Another serious complication is placental abruption, the premature separation of the placenta from the uterine wall before birth. This condition decreases oxygen and nutrient delivery to the fetus and can become a life-threatening emergency for both the patient and baby. Other risk factors not listed on this slide include maternal smoking, substance use, infections, a history of previous preterm birth, inadequate prenatal care, and certain uterine or cervical abnormalities. Understanding the causes of preterm birth helps nurses identify at-risk patients, provide appropriate education, and recognize complications that may require prompt intervention. Early prenatal care and management of maternal health conditions are important strategies for reducing the risk of preterm delivery. Respiratory complications are among the most common and serious problems seen in preterm newborns. Because the lungs are one of the last organs to fully mature before birth, premature infants often struggle to breathe effectively and maintain adequate oxygen levels. One major complication is respiratory distress syndrome, RDS. RDS occurs when the immature lungs do not produce enough surfactant, a substance that helps keep the alveoli open during breathing. Without adequate surfactant, the alveoli collapse, making breathing difficult. Signs of RDS include tachypnea, nasal flaring, grunting, chest retractions, cyanosis, and decreased oxygen saturation. Treatment may include supplemental oxygen, continuous positive airway pressure CPAP, mechanical ventilation, and surfactant replacement therapy. Another concern is apnea of prematurity. Apnea is a pause in breathing that lasts 20 seconds or longer, or a shorter pause associated with bradycardia or oxygen desaturation. It occurs because the respiratory control center in the brain is immature. Episodes may be accompanied by changes in heart rate or skin color and require close monitoring. Preterm infants are also at risk for neonatal hypoxia, which occurs when body tissues do not receive adequate oxygen. Hypoxia can result from respiratory distress, apnea, infection, or other complications. Signs may include cyanosis, poor feeding, lethargy, decreased muscle tone, and respiratory difficulty. Because oxygen is essential for organ function and growth, prolonged hypoxia can lead to serious complications affecting the brain, heart, kidneys, and other organs. Early recognition and treatment are critical. Nurses caring for preterm infants closely monitor respiratory rate, work of breathing, oxygen saturation, skin color, and heart rate. Prompt intervention helps prevent complications and supports adequate oxygenation during this critical period of development. The key concept is that immature lungs and respiratory control place preterm infants at significant risk for breathing problems, making respiratory assessment and support a priority in neonatal care. Sepsis is a serious, life-threatening infection that spreads through the bloodstream. Preterm infants are at particularly high risk because many of their body systems, especially the immune system, are not fully developed. Premature infants have fewer maternal antibodies and a limited ability to produce their own immune defenses. Their skin and mucous membranes are also more fragile, making it easier for microorganisms to enter the body. In addition, many preterm infants require invasive procedures such as IV lines, feeding tubes, or respiratory support, which can increase infection risk. The liver is immature, reducing the infant's ability to produce proteins involved in the immune response. Other body systems and enzyme functions are also immature, making it more difficult for the infant to fight infection and recover once infection develops. One challenge with neonatal sepsis is that symptoms are often subtle and nonspecific. Unlike older children and adults, preterm infants may not develop a fever. In fact, hypothermia, or low body temperature, is often an early sign of infection. Common signs and symptoms include temperature instability, especially low-temperature lethargy or decreased activity, irritability, poor feeding, or feeding intolerance, respiratory distress, including apnea, grunting, retractions, or increased oxygen requirements. Additional signs may include pallor, jaundice, abdominal distension, bradycardia, or changes in blood glucose levels. Diagnosis typically involves blood cultures, laboratory testing, and close clinical observation. Treatment usually includes prompt administration of intravenous antibiotics, respiratory support if needed, and careful monitoring in the neonatal intensive care unit and ICU. Nurses play a critical role in preventing sepsis through strict hand hygiene, aseptic technique, proper care of IV lines and equipment, and early recognition of subtle changes in the infant's condition. The key point is that sepsis can progress rapidly in preterm infants. Early recognition and treatment are essential to improve outcomes and reduce the risk of serious complications or death. Sepsis is a medical emergency that requires rapid treatment to prevent serious complications and improve survival. Because preterm infants can deteriorate quickly, treatment is often started as soon as sepsis is suspected, even before culture results are available. The primary treatment is the administration of intravenous antimicrobial medications, usually broad-spectrum antibiotics. Once culture results identify the specific organism causing the infection, antibiotic therapy may be adjusted accordingly. Maintaining warmth and adequate nutrition is also essential. Infants with sepsis often have difficulty regulating their temperature and may require an incubator or radiant warmer. Adequate nutrition supports healing and growth and may be provided through enteral feedings or intravenous fluids if the infant cannot tolerate oral feedings. Close monitoring of vital signs is critical. Nurses continuously assess temperature, heart rate, respiratory status, oxygen saturation, blood pressure, and feeding tolerance. Changes in these parameters may indicate worsening infection or response to treatment. Care should be organized to help the infant conserve energy. Excessive handling can increase oxygen consumption and metabolic demands. Clustering nursing care, minimizing disturbances, and promoting periods of rest help reduce stress on the infant. Strict standard precautions must be followed at all times. Meticulous hand hygiene is the most important intervention for preventing the spread of infection. Proper care of IV lines, feeding tubes, and other equipment also helps reduce the risk of additional infections. Depending on the severity of the illness, additional treatments may include oxygen therapy, respiratory support, intravenous fluids, or medications to support blood pressure and circulation. Early recognition, prompt antibiotic therapy, supportive care, and strict infection control practices are the cornerstones of successful sepsis management in the preterm infant. Hypoglycemia, or low blood glucose, is a common problem in preterm infants because they have limited energy reserves and increased metabolic needs. The brain relies heavily on glucose for energy, making early recognition and treatment essential. Traditionally, hypoglycemia is defined as a plasma glucose level less than 40 mmol/dl in a term infant and less than 30 mmol in a preterm infant, although specific treatment thresholds may vary by facility policy. Preterm infants are especially vulnerable because they have not remained in the uterus long enough to accumulate adequate stores of glycogen and brown fat. During the last trimester, the fetus builds energy reserves that are used after birth until feeding is well established. Premature birth interrupts this process. The problem is worsened because preterm infants have higher energy demands. The brain, heart, lungs, and other organs require significant amounts of glucose to function, and respiratory distress, infection, cold stress, or other illnesses further increase glucose consumption. Any condition that increases metabolism can increase the risk of hypoglycemia. Examples include sepsis, respiratory distress syndrome, hypothermia, and excessive activity or stress. As glucose is used more rapidly, the infant's limited glycogen stores become depleted. Signs and symptoms of hypoglycemia may include jitteriness or tremors, weak or high-pitched cry-poor feeding, lethargy, temperature instability, apnea, or respiratory distress seizures in severe cases. Treatment focuses on restoring and maintaining normal glucose levels through early and frequent feedings, glucose monitoring, and, if necessary, intravenous dextrose administration. Nurses play a key role by monitoring blood glucose levels, promoting thermoregulation, supporting adequate nutrition, and recognizing early signs of hypoglycemia before serious complications occur. The key concept is that preterm infants have limited glycogen stores and high energy needs, placing them at significant risk for hypoglycemia during the newborn period. Hypocalcemia, or low blood calcium levels, is a common metabolic problem in preterm infants. Calcium is essential for muscle contraction, nerve function, blood clotting, and heart function, so maintaining normal calcium levels is important for newborn health. During pregnancy, most fetal calcium transfer occurs during the third trimester. Because preterm infants are born before this process is complete, they have lower calcium stores at birth and are more likely to develop hypocalcemia. Early hypocalcemia usually occurs within the first 48 to 72 hours after birth. It is often related to the immature parathyroid glands, which may not respond adequately when calcium levels fall. This limits the infant's ability to maintain normal calcium balance. Late hypocalcemia typically develops after the first week of life. It is often associated with feeding practices, particularly when infants are fed cow's milk or formulas with high phosphate content. Elevated phosphate levels cause calcium levels in the blood to decrease. Signs and symptoms of hypocalcemia are related to increased neuromuscular irritability and may include jitteriness or tremors, muscle twitching, high-pitched crying, poor feeding, apnea, seizures. In severe cases, diagnosis is confirmed through laboratory testing of serum calcium levels. Treatment may include increased calcium intake through feedings or calcium supplementation, depending on the severity of the deficiency. Nurses should closely monitor preterm infants for signs of hypocalcemia, especially during the first week of life, and report symptoms promptly. The key concept is that preterm infants miss much of the calcium transfer that occurs during the third trimester, making them more vulnerable to low calcium levels after birth. Necrotizing enterocolitis (NEC) is a serious gastrointestinal disorder that primarily affects preterm infants. In NEC, portions of the intestinal tissue become inflamed and may begin to die, creating a risk for bowel perforation, sepsis, and death. Early recognition and prompt treatment are critical. Nurses closely monitor vital signs because temperature instability, apnea, bradycardia, hypotension, or worsening respiratory distress may indicate progression of the disease or the development of sepsis. Frequent assessment of the abdomen is essential. Nurses measure abdominal circumference regularly to detect increasing distension and inspect for discoloration, tenderness, or visible bowel loops. Increasing abdominal girth may indicate worsening inflammation or bowel injury. Nurses also auscultate bowel sounds. Decreased or absent bowel sounds may indicate reduced intestinal activity and worsening disease. Gastric residuals, vomiting, and bloody stools are additional findings that should be reported promptly. Infants with NEC are typically kept NPO nothing by mouth to allow the bowel to rest. Nutrition and hydration are provided through intravenous fluids and total parenteral nutrition (TPN). When feedings are restarted, they are resumed slowly and carefully according to provider orders while monitoring for signs of intolerance. Strict infection prevention and control practices are essential because NEC can lead to sepsis. Nurses use meticulous hand hygiene, aseptic technique, and careful monitoring for signs of infection. In severe cases, surgical intervention may be necessary. If portions of the intestine become necrotic or perforated, the damaged bowel may need to be removed. Some infants may require a temporary ostomy until the bowel heals. Nurses also support the family by explaining treatments, providing updates on the infant's condition, and helping parents cope with the stress of having a critically ill newborn. The key nursing priorities for NEC are early recognition, bowel rest, careful monitoring of abdominal status, prevention of infection, and prompt intervention if complications develop. Proper positioning is an important part of caring for the preterm infant. Because these infants have immature lungs, limited energy reserves, and fragile skin, positioning can improve breathing, promote growth, and reduce complications. In the NICU, preterm infants are often positioned sideline or prone with the head of the mattress slightly elevated, as ordered and while under continuous monitoring. These positions can help decrease the work of breathing, improve oxygenation, and promote lung expansion. Appropriate positioning also supports more organized sleep patterns. Sleep is essential for growth and brain development, and minimizing unnecessary movement helps conserve energy. Energy that would otherwise be used for physical activity can instead be directed toward growth, healing, and development. Positioning should also promote the drainage of secretions and help reduce the risk of aspiration. Nurses carefully monitor respiratory status and adjust positioning based on the infant's condition and provider orders. Because preterm infants have very delicate skin and limited subcutaneous tissue, they should not remain in one position for extended periods. Frequent repositioning helps prevent pressure injuries, skin breakdown, and flattening of the head. Nurses also use developmental care techniques, such as nesting and supportive positioning devices, to mimic the flexed position of the uterus. These interventions promote comfort, physiologic stability, and neuromuscular development. The key nursing goals are to improve oxygenation, conserve energy, support growth and development, and protect the infant's fragile skin through frequent assessment and repositioning. A postterm newborn is an infant born at 42 weeks gestation or later. While these infants are often larger than average, remaining in the uterus beyond the expected due date can increase the risk of complications for both the fetus and the newborn. One major concern is that the placenta begins to age and function less effectively after a certain point. As placental function declines, the delivery of oxygen and nutrients to the fetus may decrease, increasing the risk of complications before and during birth. Because of reduced placental function, postterm pregnancies may result in fetal distress, particularly during labor. The fetus may experience decreased oxygenation, leading to abnormal fetal heart rate patterns and an increased need for intervention during delivery. Postterm infants are also at increased risk for meconium aspiration syndrome. As the fetus becomes stressed, meconium may be passed into the amniotic fluid and inhaled into the lungs before or during birth, causing respiratory problems. Although postterm infants may appear large, they can have decreased subcutaneous fat because placental insufficiency may limit nutrient delivery. These infants often have a characteristic appearance that includes dry, cracked, peeling skin, long fingernails, and reduced vernix caseosa. The mortality rate of postterm infants is higher than that of full-term newborns, and morbidity rates are also increased. Common complications include birth trauma from larger size, hypoglycemia, respiratory distress, meconium aspiration, and problems related to decreased placental function. After birth, nurses closely monitor postterm infants for signs of respiratory distress, hypoglycemia, feeding difficulties, and temperature instability. Careful assessment and early intervention help reduce complications and promote a successful transition to extradural life. The key concept is that although postterm infants have had a longer gestation, declining placental function places them at increased risk for fetal distress, respiratory complications, and other newborn health problems. Postterm infants are at increased risk for complications because the placenta becomes less efficient at delivering oxygen and nutrients as pregnancy continues beyond 42 weeks. As placental function declines, the fetus may experience chronic stress and decreased oxygenation. One serious complication is asphyxia, which occurs when the fetus or newborn does not receive enough oxygen. Prolonged oxygen deprivation can lead to organ damage, neurologic injury, or even death if not recognized and treated promptly. Meconium aspiration syndrome is another common concern. Fetal stress may cause the passage of meconium into the amniotic fluid before birth. If the infant inhales the meconium-stained fluid, airway obstruction, inflammation, and respiratory distress can occur. Postterm infants may also have poor nutritional status. Although some postterm infants are large, others develop a thin, wasted appearance because placental insufficiency reduces the delivery of nutrients during the final weeks of pregnancy. Chronic low oxygen levels may stimulate the fetus to produce more red blood cells, leading to polycythemia or an increased red blood cell count. This can make the blood thicker and increase the risk for circulatory problems and jaundice. Some postterm infants are macrosomic, meaning they are unusually large. Increased fetal size can make delivery more difficult and increase the risk of birth trauma, shoulder dystocia, cesarean birth, and maternal injury. The incidence of certain birth defects and congenital abnormalities is also slightly higher in postterm pregnancies. In addition, severe hypoxia or birth complications can increase the risk of seizures during the newborn period. Following delivery, nurses closely monitor postterm infants for signs of respiratory distress, hypoglycemia, jaundice, feeding difficulties, neurologic changes, and temperature instability. Early identification of complications is essential for improving outcomes. The key concept is that prolonged pregnancy can lead to placental insufficiency, increasing the risk for oxygen deprivation, meconium aspiration, birth trauma, and other complications that require close newborn assessment and monitoring. Birth defects, also called congenital anomalies, are abnormalities that are present at birth. They may be identified before birth through prenatal testing or discovered during the newborn assessment after delivery. Birth defects can involve an abnormality of structure, meaning a body part does not form correctly. Examples include cleft lip, cleft palate, spina bifida, and congenital heart defects. Some birth defects involve function, meaning an organ or body system does not work properly even though it may appear normal. Examples include hearing impairments, vision disorders, or certain neurologic conditions. Other birth defects involve metabolism, where the body cannot properly process nutrients or chemicals. Examples include phenylketonuria, PKU, and other inherited metabolic disorders. Many of these conditions are identified through newborn screening tests shortly after birth. Birth defects may result from genetic factors, environmental exposures, maternal illnesses, infections, medications, substance use, nutritional deficiencies, or a combination of factors. In many cases, the exact cause is unknown. The effects of birth defects vary greatly. Some are mild and require little or no treatment, while others may cause physical disabilities, developmental delays, intellectual disabilities, chronic health problems, or shortened life expectancy. Severe congenital anomalies may be incompatible with life and can be fatal. Nurses play an important role in the early identification of congenital anomalies through careful newborn assessment. Nursing responsibilities include monitoring the infant's condition, supporting the family, providing education, coordinating care with specialists, and assisting with diagnostic testing and treatment. The key concept is that birth defects may affect structure, function, or metabolism, and their impact can range from minor to life-threatening. Early detection and intervention improve outcomes and support optimal growth and development. Birth defects can be classified into several categories based on their cause and the body system affected. Understanding these classifications helps nurses recognize common conditions and understand their impact on newborn health. The first category is malformations, also called congenital malformations. These are structural abnormalities that develop during fetal growth and are present at birth. Examples include cleft lip, cleft palate, spina bifida, congenital heart defects, and clubfoot. Another category is inborn errors of metabolism. These are inherited disorders in which the body cannot properly process certain nutrients or substances because of missing or defective enzymes. Examples include phenylketonuria, PKU, galactosemia, and maple syrup urine disease. Many of these disorders are detected through routine newborn screening. Disorders of the blood are another classification. These conditions affect blood cells, clotting factors, or hemoglobin. Examples include sickle cell disease, thalassemia, and hemophilia. Early diagnosis is important because many blood disorders require lifelong management. Chromosomal abnormalities occur when there is an abnormal number or structure of chromosomes. These conditions often affect multiple body systems and may result in developmental delays or intellectual disabilities. Examples include Down syndrome, trisomy 21, trisomy 18 Edwards syndrome, Turner syndrome, and Klinefelter syndrome. The final category is perinatal injuries. These are injuries that occur before, during, or shortly after birth and may result from difficult deliveries, oxygen deprivation, infection, or trauma. Examples include brachial plexus injuries, clavicle fractures, intracranial hemorrhage, and hypoxic ischemic injury. Nurses play an important role in identifying abnormalities, assisting with diagnostic testing, providing family education, and coordinating care with specialists. The key concept is that birth defects may result from structural abnormalities, metabolic disorders, blood disorders, chromosomal abnormalities, or perinatal injuries, and early recognition improves outcomes and supports family-centered care. Neural tube defects (NTDs) are among the most common congenital abnormalities affecting the nervous system. They occur very early in pregnancy when the neural tube, which develops into the brain and spinal cord, fails to close properly. The neural tube normally closes during the first 4 weeks of pregnancy, often before a person realizes they are pregnant. When closure does not occur correctly at either the cranial end or the caudal end, defects involving the brain or spinal cord can result. One common condition associated with neural tube defects is spina bifida. Spina bifida occurs when the vertebrae fail to close completely around the spinal cord. The severity varies depending on the extent of the defect. Infants may experience weakness or paralysis of the lower extremities, bowel and bladder dysfunction, and orthopedic complications. Another condition often associated with neural tube defects is hydrocephalus, which is an abnormal accumulation of cerebrospinal fluid within the ventricles of the brain. As fluid accumulates, pressure increases within the skull, causing enlargement of the head and potentially damaging brain tissue if left untreated. Many infants require placement of a ventriculoperitoneal VP shunt to drain excess fluid. One of the most important preventive measures for neural tube defects is adequate folic acid intake before conception and during early pregnancy. Folic acid supplementation has been shown to significantly reduce the risk of neural tube defects. Nursing care focuses on early identification, protecting exposed nervous tissue when present, monitoring neurologic function, preventing infection, supporting family education, and coordinating care with specialists. The key concept is that neural tube defects occur when the neural tube fails to close properly during early fetal development, resulting in conditions such as spina bifida and hydrocephalus. Intracranial pressure (ICP) refers to the pressure within the skull caused by brain tissue, blood, and cerebrospinal fluid. Conditions such as hydrocephalus, brain injury, bleeding, infection, or tumors can cause ICP to rise. Increased intracranial pressure is a medical emergency because it can reduce blood flow to the brain and lead to permanent neurologic damage. One of the classic signs of increasing ICP is rising blood pressure accompanied by a decreasing pulse rate and slowing respirations. This pattern, known as Cushing's triad, suggests significant pressure on the brain and requires immediate intervention. Infants may develop a high-pitched cry, which is often an early sign of neurologic irritation. Parents frequently describe this cry as unusual, shrill, or difficult to console. Changes in the eyes may also occur. Unequal pupil size, sluggish reaction to light, or fixed pupils can indicate pressure affecting the cranial nerves and brainstem. Because infants have open cranial sutures and fontanelles, increased pressure may cause bulging fontanelles. Enlargement of head circumference and widening of cranial sutures may also be observed in infants with hydrocephalus. Older children, whose sutures have already fused, often experience headaches, especially in the morning, because the skull cannot expand to accommodate increasing pressure. Additional symptoms include irritability, restlessness, lethargy, decreased responsiveness, vomiting, and poor feeding. Vomiting may occur without nausea and is often related to pressure on the vomiting center in the brain. As intracranial pressure continues to rise, neurologic function can deteriorate rapidly, leading to seizures, altered consciousness, and respiratory failure. Nurses should closely monitor neurologic status, vital signs, head circumference in infants, pupil responses, feeding patterns, and behavior changes. Early recognition of increasing intracranial pressure is critical because prompt treatment can prevent permanent brain injury and improve outcomes. Hydrocephalus is a condition in which excessive cerebrospinal fluid (CSF) accumulates within the ventricles of the brain. As fluid builds up, pressure inside the skull increases, which can compress brain tissue and interfere with normal brain development and function. Hydrocephalus occurs when there is an imbalance between the production and absorption of cerebrospinal fluid, when the normal flow of CSF is blocked, or when the ventricles develop abnormally. It may be congenital or develop after birth due to infection, hemorrhage, or injury. In infants, because the cranial sutures and fontanelles have not yet closed, increasing pressure often causes an increase in head circumference. Nurses should measure and document head circumference regularly to monitor for abnormal growth patterns. Common signs of hydrocephalus in infants include rapid increase in head size, bulging fontanelles, widely separated cranial sutures, high-pitched cry. Poor feeding, vomiting, irritability, or lethargy, sunsetting eyes, where the eyes appear driven downward and the sclera is visible above the iris as intracranial pressure increases. Neurologic symptoms may worsen and can eventually affect breathing, circulation, and consciousness. Diagnosis is typically confirmed using imaging studies such as ultrasound, computed tomography (CT), or magnetic resonance imaging (MRI) to evaluate ventricular enlargement. The most common treatment is placement of a ventriculoperitoneal (VP) shunt, which diverts excess cerebrospinal fluid from the ventricles of the brain into the peritoneal cavity, where it can be absorbed. Some infants may be candidates for an endoscopic third ventriculostomy (ETV), depending on the cause of the hydrocephalus. Nursing care includes monitoring head circumference, neurologic status, fontanelles, feeding tolerance, and signs of increasing intracranial pressure. After shunt placement, nurses must assess for signs of shunt malfunction or infection, including vomiting, lethargy, fever, irritability, and a return of symptoms associated with increased intracranial pressure. The key concept is that hydrocephalus results from excess cerebrospinal fluid within the brain's ventricles, leading to increased intracranial pressure and enlargement of the infant's head. Early detection and treatment help prevent permanent neurologic damage. The manifestations of hydrocephalus vary depending on how quickly cerebrospinal fluid accumulates and the severity of the pressure increase within the brain. Because an infant's cranial sutures and fontanelles have not yet fused, the skull can expand to accommodate the excess fluid. As a result, symptoms in infants differ from those seen in older children and adults. One of the earliest and most recognizable signs is a rapid increase in head circumference. The nurse should measure head circumference regularly and compare it with expected growth patterns. An abnormally fast increase may indicate worsening hydrocephalus. As fluid accumulates, the cranial sutures separate to accommodate the enlarging ventricles. The anterior fontanelle may become tense or bulging even when the infant is calm and upright. The scalp may appear thin, shiny, and stretched, and the superficial veins become more visible and dilated because of increased pressure beneath the skin. Additional manifestations may include bulging fontanelles, prominent scalp veins, sunsetting eyes, downward deviation of the eyes, high-pitched cry. Poor feeding, vomiting, irritability, or lethargy, developmental delays, seizures, in severe cases as intracranial pressure continues to rise. The infant may show signs of neurologic deterioration, including changes in level of consciousness and abnormal vital signs. Early recognition is critical because prolonged increased intracranial pressure can cause permanent brain injury. For LPN practice, important assessments include monitoring head circumference, fontanelle status, neurologic behavior, feeding patterns and signs of increased intracranial pressure, and promptly reporting abnormal findings to the registered nurse or healthcare provider. Key point: the classic findings of hydrocephalus in infants are enlarged head size, separated sutures, bulging fontanelles, a shiny scalp with prominent veins, and signs of increased intracranial pressure. Hydrocephalus is diagnosed using tests that show excess cerebrospinal fluid (CSF) and enlarged ventricles. Common diagnostic tools include cranial ultrasound echoencephalography, Connecticut scans, MRI, transillumination, and occasionally a ventricular tap. Treatment focuses on reducing pressure within the brain. Medications may temporarily decrease CSF production, but the most common treatment is surgical placement of a ventriculoperitoneal VP shunt, which drains excess fluid from the brain to the abdomen for absorption. After shunt placement, nurses monitor for signs of shunt malfunction or infection, including vomiting, irritability, lethargy, fever, seizures, bulging fontanelles, or increasing head size. Key point: the primary treatment for hydrocephalus is a VP shunt, which helps relieve pressure and prevent brain damage. A ventriculoperitoneal VP shunt is the most common treatment for hydrocephalus. The shunt is surgically placed to drain excess cerebrospinal fluid CSF from the ventricles of the brain into the abdominal cavity where it can be absorbed. Although medications may temporarily reduce CSF production, surgery is usually required for long-term management. After placement, the nurse monitors for signs of shunt malfunction or infection, such as fever, vomiting, irritability, lethargy, seizures, or increasing head circumference. Because a shunt can become infected, persistent infections may require the shunt to be removed and replaced. Before shunt surgery, nursing care focuses on preventing complications and monitoring for worsening increased intracranial pressure. Because infants with hydrocephalus often have enlarged heads, frequent position changes are important to prevent skin breakdown and pressure injuries. The head should always be carefully supported during handling and feedings. The nurse should regularly measure head circumference and monitor vital signs, fontanelles, feeding patterns, and neurologic status for signs of increasing intracranial pressure. These assessments help evaluate disease progression and provide a baseline before surgery. Key point: preoperative care focuses on protecting the infant, monitoring neurologic status, preventing skin breakdown, and tracking head growth until shunt placement can be performed. After VP shunt surgery, nursing care focuses on monitoring for complications and promoting healing. The nurse should frequently assess for signs of increased intracranial pressure, such as vomiting, irritability, lethargy, bulging fontanelles, or changes in vital signs, which may indicate shunt malfunction. Preventing infection is a priority. The incision and shunt sites should be monitored for redness, swelling, drainage, or fever. In some cases, the surgeon may order the shunt reservoir, or pump, to be depressed to assess function. Positioning depends on the surgeon's orders and the infant's condition. The nurse should also assess pain regularly and provide comfort measures or prescribe pain medication as needed. Key point: postoperative care focuses on monitoring shunt function, preventing infection, assessing for increased intracranial pressure, and providing pain management. Before discharge, parents should be taught how to recognize signs of VP shunt malfunction and when to seek immediate medical attention. If instructed by the surgeon, parents may also learn how to assess or pump the shunt reservoir. A malfunctioning shunt can cause a return of increased intracranial pressure. In infants, warning signs include bulging fontanelles, vomiting, irritability, poor feeding, increasing head size, and a high-pitched cry. In older children, symptoms may include headache, lethargy, nausea or vomiting, changes in level of consciousness, vision changes, or declining school performance. Parents should understand that shunt malfunction is a medical emergency and requires prompt evaluation. The primary treatment for spina bifida is surgical closure of the spinal defect, usually within the first 24 to 48 hours after birth. Early surgery helps reduce the risk of infection, trauma to exposed nerves, and further neurologic damage, but it does not reverse existing nerve injury. The long-term outcome depends on the location and severity of spinal cord involvement. Children with more extensive defects may experience paralysis, mobility limitations, bowel and bladder dysfunction, orthopedic problems, and hydrocephalus. Many require ongoing multidisciplinary care, rehabilitation, and support services. Unlike rehabilitation, which focuses on restoring lost function, habilitation helps a child develop skills that may never have fully developed because of a congenital condition such as spina bifida. The goal is to maximize the child's independence, abilities, and quality of life. Care focuses on helping the child make the best use of unaffected body parts and achieve the highest possible level of physical, emotional, social, and intellectual development. Physical therapy, occupational therapy, assistive devices, and educational support may all play important roles. Nurses also support the child and family in building self-esteem, independence, and coping skills. Encouraging participation in normal childhood activities helps promote a positive self-image and overall well-being. Cleft lip is a congenital defect in which there is a visible opening or separation in the upper lip. The defect can range from a small notch to a large opening that extends into the nose. It occurs during early fetal development when the tissues that form the upper lip fail to fuse completely. Embryologically, cleft lip results from failure of the maxillary process and medial nasal process to join properly during the first trimester of pregnancy. The exact cause is often multifactorial, involving both genetic and environmental factors. Risk factors may include a family history of cleft defects, maternal smoking, alcohol use, certain medications, poor nutrition, and inadequate folic acid intake during pregnancy. Cleft lip occurs more frequently in male infants and may occur alone or with a cleft palate. Newborns with a cleft lip may have difficulty creating a proper seal around the nipple, which can make feeding challenging. However, many infants can feed successfully with specialized bottles and feeding techniques. Treatment usually involves surgical repair, often within the first few months of life. The goals of surgery are to improve appearance, support normal feeding and speech development, and promote normal facial growth. Nurses play an important role in supporting feeding, educating parents, and preparing families for surgical correction and long-term follow-up care. The primary treatment for a cleft lip is surgical repair called cheiloplasty. Surgery is commonly performed by about 3 months of age, provided the infant is healthy and growing appropriately. This timing helps improve feeding, appearance, and future speech development. Before surgery, some infants may require specialized feeding equipment, such as a specialized bottle, nipple, or syringe feeder, because they may have difficulty creating suction during feeding. The nurse should monitor weight gain closely and teach parents feeding techniques that promote adequate nutrition. After surgical repair, infants may wear elbow restraints, sometimes called no-nos, to prevent them from touching or scratching the incision site. Nurses should remove restraints one arm at a time according to facility policy to assess skin integrity and provide range of motion exercises. Postoperative nursing care focuses on protecting the surgical site, managing pain, maintaining adequate nutrition and hydration, and monitoring for signs of infection. Parent education is essential so caregivers understand feeding instructions, incision care, and the importance of follow-up appointments. A cleft palate occurs when the two sides of the palate fail to fuse during fetal development, usually between the 7th and 12th weeks of gestation. This results in an opening between the oral cavity and the nasal cavity. The defect may involve only the soft palate or extend through both the hard and soft palate. Because there is a direct connection between the mouth and nose, infants often experience feeding difficulties, including poor suction, prolonged feeding times, choking, and milk regurgitation through the nose. These infants may require specialized nipples or feeding devices to ensure adequate nutrition and growth. Children with cleft palate are also at increased risk for recurrent ear infections and respiratory infections because the abnormal anatomy affects drainage of the middle ear and upper airway. As the child grows, speech and language development may also be affected if the defect is not corrected. Nursing care focuses on supporting feeding, monitoring weight gain, preventing aspiration, educating parents, and preparing the family for surgical repair and long-term follow-up. Treatment of a cleft palate focuses on improving the child's feeding, speech, hearing, dental development, and appearance. The primary goal is surgical closure of the palate, called palatoplasty, which is typically performed between 9 and 18 months of age, depending on the child's condition and the surgeon's recommendations. Before surgery, nurses help families manage feeding difficulties and monitor growth and weight gain. After repair, many children require ongoing support from a multidisciplinary team that may include speech therapists, dentists, orthodontists, audiologists, and surgeons. Successful treatment helps improve the child's ability to eat, speak clearly, and develop normal dental structures. It also promotes healthy social development and a positive self-image. Because treatment often continues throughout childhood, family education and support are important components of care. After cleft lip or cleft palate repair, nursing care focuses on protecting the surgical site, preventing infection, controlling pain, and promoting healing. Infants should be kept calm because excessive crying or vigorous sucking can place stress on the repair and increase the risk of wound disruption. Positioning is important. After cleft lip repair, infants are usually positioned on their back or side to prevent pressure on the incision. After cleft palate repair, sideline or prone positioning may be ordered to promote drainage and protect the surgical site. Always follow the surgeon's specific instructions. The incision should be assessed frequently and cleansed gently as prescribed to prevent crusting, infection, and excessive scarring. Elbow restraints may be used temporarily to prevent the infant from touching the repair. Nurses should remove restraints one arm at a time according to policy to assess skin integrity and provide range of motion exercises. Pain management is essential because discomfort can increase crying and place stress on the surgical repair. In addition to medication, cuddling, rocking, and comforting measures help meet the infant's emotional needs and support healing. Following cleft lip or palate repair, nutrition is reintroduced gradually according to the surgeon's orders. Foods and fluids should be provided in a manner that avoids excessive sucking, which could place stress on the surgical repair. Older children should avoid using straws until healing is complete. Good oral hygiene is essential to reduce the risk of infection. After feedings, the mouth is often rinsed with small amounts of clear water to help remove food particles and keep the surgical site clean. Many children require ongoing monitoring of speech development. Early speech therapy and encouragement of proper pronunciation can help improve communication skills as the child grows. Activities should be calm and comforting during recovery. Excessive crying increases pressure on the surgical site and can interfere with healing. Quiet activities such as reading, coloring, or cuddling are preferred. Long-term follow-up is important because children with cleft palate are at increased risk for recurrent ear infections, hearing problems, dental abnormalities, and tooth decay. Regular medical, dental, and speech evaluations help promote optimal outcomes. Key point: postoperative care focuses on protecting the repair, maintaining nutrition and oral hygiene, promoting speech development, minimizing crying, and monitoring for complications such as ear infections and dental problems. Clubfoot, also called talipes, is one of the most common congenital musculoskeletal deformities. It occurs when the foot is twisted out of its normal position, causing it to turn inward, or, less commonly, outward. The most common type is talipes equinovarus, in which the foot points downward and inward. In severe cases, if left untreated, the child may walk on the toes and outer edge of the foot rather than the sole. Clubfoot frequently affects both feet, although it can occur on only one side. The exact cause is not always known, but genetics and environmental factors may contribute. Early diagnosis is important because treatment started shortly after birth produces the best outcomes. Treatment usually begins with serial casting and gentle manipulation, often using the Ponseti method, to gradually move the foot into a normal position. Some children may require bracing or surgery if casting alone is not successful. Treatment for clubfoot should begin as early as possible, ideally within the first few weeks of life. Early intervention is important because the bones, muscles, and tendons are still flexible and easier to correct. Initial treatment is usually conservative and includes gentle stretching exercises and serial casting or splinting to gradually move the foot into the correct position. The Ponseti method, which combines manipulation and casting, is the most common treatment approach. Nurses should monitor circulation, skin integrity, and comfort while casts or braces are in place. Parents should be taught proper cast care and the importance of keeping follow-up appointments to ensure correction progresses as planned. If conservative treatment is unsuccessful, surgical correction may be needed, typically within the first year of life. After surgery, continued bracing and physical therapy may be necessary to maintain proper alignment. Key point: early treatment with stretching, casting, and bracing provides the best outcomes and may. Parent education is a critical part of clubfoot treatment. Families should understand that consistent adherence to casting, bracing, stretching exercises, and follow-up appointments is essential for successful correction. Failure to follow the treatment plan can result in recurrence of the deformity and long-term mobility problems. Nurses should teach parents proper cast care, including keeping the cast clean and dry, checking the toes for circulation, monitoring for skin irritation, and reporting signs of swelling, discoloration, foul odor, or pain. Parents should never place objects inside the cast. Emotional support is also important. Parents may feel overwhelmed by the diagnosis and the lengthy treatment process. Reassurance that most children achieve excellent outcomes with early treatment can help reduce anxiety. As the child grows, encouraging participation in normal activities can help promote a positive self-image and prevent feelings of isolation. Developmental hip dysplasia (DDH) is a condition in which the hip joint does not develop normally. The femoral head may be unstable, partially displaced subluxated, or completely dislocated from the hip socket. The condition ranges from mild instability to complete dislocation. DDH occurs much more frequently in girls than boys and may be associated with factors such as breech presentation, family history, or limited fetal movement in utero. Early detection is important because treatment is most successful when started during infancy. In newborns, healthcare providers screen for DDH using the Barlow and Ortolani maneuvers. As the child grows, signs may include limited hip abduction, unequal gluteal folds, leg length differences, limping, or a waddling gait. If untreated, DDH can lead to abnormal walking patterns, chronic pain, and early arthritis later in life. Early diagnosis and treatment help promote normal hip development and mobility. Developmental hip dysplasia DDH is often identified during routine newborn and infant assessments. Two important screening maneuvers are the Barlow test and the Ortolani test. The Barlow test is used to determine whether the hip can be dislocated. While stabilizing the pelvis, the healthcare provider gently adducts the hip and applies pressure. A positive Barlow test occurs when the femoral head can be felt slipping out of the acetabulum, indicating hip instability. The Ortolani test is used to determine whether a dislocated hip can be reduced back into the socket. The provider gently abducts the hips while applying upward pressure. A positive Ortolani sign is a palpable or audible click or clunk as the femoral head moves back into the acetabulum. If screening findings are abnormal, hip ultrasound is commonly used in infants younger than 4 to 6 months because the hip bones are not yet fully ossified. In older infants and children, X-rays may be used to confirm the diagnosis. The goal of treatment for developmental hip dysplasia DDH is to keep the head of the femur positioned correctly within the acetabulum, so the hip joint can develop normally. Early treatment is important because the bones and cartilage are still growing and can be molded into the correct position. In infants, the hips are maintained in flexion and abduction for several weeks. This positioning keeps the femoral head securely within the hip socket and promotes normal development of the acetabulum. As the femoral head remains in place, constant pressure helps the socket become deeper and more stable. The most common treatment for infants is a Pavlik harness, which holds the hips in the desired position while still allowing some movement. Parents should never adjust the harness straps unless instructed by the orthopedic provider. If conservative treatment is unsuccessful or the diagnosis is delayed, surgical intervention may be necessary. Early identification and treatment greatly improve outcomes and help prevent long-term complications such as gait abnormalities, chronic pain, and early osteoarthritis. Inborn errors of metabolism are genetic disorders that affect the body's ability to break down, process, or use certain nutrients. Although present at birth, symptoms may not become noticeable until the newborn begins feeding and metabolic waste products start to accumulate in the body. Because these disorders can quickly become life-threatening, early recognition is essential. Nurses should monitor for signs such as lethargy, poor feeding, hypotonia, decreased muscle tone, tachypnea, rapid breathing, vomiting, and unusual body or urine odors. Some metabolic disorders, such as phenylketonuria PKU or maple syrup urine disease, may produce characteristic odors. Newborn screening programs are designed to identify many metabolic disorders before symptoms become severe. Early diagnosis and treatment, often involving special diets or medications, can prevent serious complications such as developmental delays, neurologic damage, and death. Phenylketonuria PKU is an inherited metabolic disorder in which the body cannot properly break down phenylalanine, an amino acid found in protein-containing foods. This occurs because the infant lacks the enzyme needed to convert phenylalanine into other substances the body can use. As phenylalanine accumulates in the blood, it becomes toxic to the developing brain. Infants are usually normal at birth, but without treatment, the buildup can lead to severe intellectual disability, developmental delays, seizures, and behavioral problems. PKU is identified through the newborn screening test, which is why early screening is so important. Treatment involves a lifelong diet low in phenylalanine, including special formulas and careful monitoring of food intake. Early diagnosis and treatment can allow children with PKU to grow and develop normally. Teaching point. PKU is one of the best examples of why newborn screening is critical. Early detection and dietary management can prevent permanent neurologic damage. The primary goal of nursing care for children with phenylketonuria PKU is to prevent the buildup of phenylalanine and protect the developing brain. Because treatment is largely dietary, parent education is essential. Parents should be taught how to read food labels carefully and identify foods high in phenylalanine, such as many protein-rich foods and products containing the artificial sweetener aspartame. Adherence to the prescribed diet is critical throughout childhood and often for life. Regular follow-up appointments and blood tests are necessary to monitor phenylalanine levels and ensure the diet is effective. A registered dietitian plays an important role in helping families plan meals, maintain adequate nutrition, and manage dietary restrictions. Because PKU is an inherited disorder, genetic counseling may be recommended to help families understand the condition, recurrence risks, and future family planning considerations. Key point: early diagnosis, strict dietary management, and ongoing monitoring allow most children with PKU to achieve normal growth and development. Galactosemia is an inherited metabolic disorder in which the infant cannot properly metabolize galactose, a sugar that is produced when the body breaks down lactose, the primary sugar found in milk and milk products. The disorder occurs because the enzyme needed to convert galactose into glucose is absent or deficient. As galactose accumulates in the blood and tissues, it becomes toxic and can cause serious damage to multiple organs. Symptoms often begin shortly after the infant starts consuming breast milk or formula. It may include poor feeding, vomiting, lethargy, jaundice, failure to thrive, and hypoglycemia. If untreated, galactosemia can lead to severe complications such as liver damage or cirrhosis, cataracts, intellectual disability, developmental delays, and life-threatening infections. Because milk is usually the infant's primary source of nutrition, early identification through newborn screening is essential. Treatment requires the immediate elimination of galactose and lactose from the diet. Infants are typically switched to a soy-based or lactose-free formula, and lifelong dietary management is often necessary. Key point: any newborn diagnosed with galactosemia should stop receiving milk-containing feedings immediately to prevent serious complications. Mug/content note: replace the outdated term mental retardation with intellectual disability or cognitive impairment. Additionally, consider changing galactose is present in milk in the form of sugar to lactose. The primary sugar in milk breaks down into glucose and galactose. This is more scientifically accurate. The treatment of galactosemia focuses on completely eliminating galactose and lactose from the child's diet. Because lactose is found in breast milk and standard infant formulas, these feedings must be stopped immediately once the diagnosis is confirmed. Infants are typically switched to lactose-free or soy-based formulas, which provide adequate nutrition without exposing the child to galactose. Early dietary intervention can prevent serious complications such as liver damage, cataracts, developmental delays, and intellectual disability. Nurses play an important role in educating parents about reading food labels, avoiding hidden sources of lactose, and ensuring strict dietary compliance. Families should understand that dietary restrictions are lifelong and essential for preventing complications. Parental support and education are critical, as the diagnosis can be overwhelming. Referrals to a dietitian and genetic counselor can help families manage the condition and maintain the child's long-term health and development. Down syndrome trisomy 21 is the most common chromosomal abnormality and occurs when a child has an extra copy of chromosome 21. The risk increases with advanced maternal age, particularly age 35 and older, although most children with Down syndrome are born to younger mothers because younger women have more pregnancies overall. Children with Down syndrome have varying degrees of intellectual disability, ranging from mild to moderate in most cases. They may also have characteristic physical features such as a flat facial profile, upward slanting eyes, low muscle tone hypotonia, a single palmar crease, and a protruding tongue. Many children require additional support with activities of daily living such as eating, dressing, toileting, and self-care skills. Early intervention programs, physical therapy, occupational therapy, speech therapy, and educational support help children reach their maximum developmental potential. Children with Down syndrome are also at increased risk for congenital heart defects, hearing loss, vision problems, thyroid disorders, and gastrointestinal abnormalities, making regular health screenings important. Key point: focus on the child's abilities rather than limitations. With appropriate medical care, family support, and early intervention, many individuals with Down syndrome lead healthy, productive, and fulfilling lives. Presenter notes: hemolytic disease of the newborn erythroblastosis fetalis, hemolytic disease of the newborn HDN, also called erythroblastosis fetalis, occurs when the mother's immune system destroys the fetus's red blood cells. The most common cause is Rh incompatibility, which develops when an Rh-negative mother carries an Rh-positive fetus. During pregnancy or birth, fetal blood cells may enter the maternal circulation. The mother's immune system recognizes the Rh-positive cells as foreign and produces antibodies against them. In a subsequent pregnancy, these antibodies can cross the placenta and attack the red blood cells of an Rh-positive fetus, causing hemolysis. The destruction of fetal red blood cells can result in anemia, jaundice, hepatosplenomegaly, heart failure, hydropias fetalis, and even fetal death if severe. Signs may become apparent before birth or shortly after delivery. Today, most cases are prevented through the administration of rotimmune globulin rogam to Rh-negative mothers during pregnancy and after the birth of an Rh-positive infant. This prevents the mother's immune system from becoming sensitized to Rh-positive blood cells. Key point: Rh incompatibility is largely preventable with appropriate prenatal care and timely administration of rogam. Normally, maternal and fetal blood do not mix. However, small amounts of fetal blood can enter the mother's circulation during pregnancy, birth, miscarriage, trauma, or invasive procedures. If an Rh-negative mother is exposed to Rh-positive fetal blood, her immune system may become sensitized and begin producing antibodies against Rh-positive red blood cells. During a subsequent pregnancy with an Rh-positive fetus, these maternal antibodies can cross the placenta and destroy fetal red blood cells. This process causes hemolysis, leading to fetal anemia. As anemia becomes severe, the fetal heart must work harder to deliver oxygen, which can result in heart failure, generalized edema hydrops fetalis, and even fetal death if untreated. The severity of the disease depends on the amount of antibody production and the degree of red blood cell destruction. Early detection through prenatal testing and prevention with rotimmune globulin rogam have dramatically reduced the incidence of severe disease. Key point: maternal antibodies, not the Rh-positive blood itself, because the destruction of fetal red blood cells. The greatest risk occurs after the mother has become sensitized to positive blood. After birth, the newborn is evaluated for hemolytic disease using a direct Coombs test performed on umbilical cord blood. A positive test indicates that maternal antibodies are attached to the infant's red blood cells and are causing hemolysis. Clinical manifestations vary depending on the severity of red blood cell destruction. Anemia develops because large numbers of erythrocytes are being destroyed. As hemolysis continues, bilirubin levels rise rapidly, causing pathologic jaundice, which typically appears within the first 24 hours after birth. This early onset of jaundice is abnormal and requires immediate evaluation. The liver and spleen often become enlarged because they are working harder to remove damaged blood cells and produce new ones. Severe anemia decreases the blood's ability to carry oxygen to tissues, which can result in poor perfusion, respiratory distress, and cardiovascular compromise. In severe cases, infants may develop hydrops fetalis, shock, or heart failure due to the extreme workload placed on the cardiovascular system. Treatment focuses on early identification and prevention of complications from severe anemia and hyperbilirubinemia. Newborns require frequent laboratory monitoring, including bilirubin levels, hemoglobin, hematocrit, blood type, and direct Coombs testing, to determine disease severity and guide treatment decisions. Drug therapy may include medications that support red blood cell production or help manage complications. Phototherapy is commonly used to reduce elevated bilirubin levels by converting bilirubin into a form that can be more easily eliminated from the body. During phototherapy, nurses monitor temperature, hydration status, skin integrity, and eye protection. For severe cases, an exchange transfusion may be necessary. This procedure removes antibody-coated red blood cells and excess bilirubin while replacing them with compatible donor blood. Exchange transfusions help prevent kernicterus, a form of bilirubin-induced brain damage, and improve oxygen-carrying capacity. Intracranial hemorrhage is bleeding within the newborn's skull and is one of the most serious birth injuries. It is seen most often in preterm infants because their cerebral blood vessels are fragile and easily damaged. Bleeding may occur as a result of birth trauma, hypoxia oxygen deprivation, anoxia, difficult deliveries, precipitous births, or prolonged labor. The severity of symptoms depends on the location and extent of the bleeding. Mild hemorrhages may cause few noticeable symptoms, while severe hemorrhages can lead to significant neurologic impairment. Common manifestations include poor feeding, lethargy, apnea, seizures, a high-pitched cry, bulging fontanelles, respiratory distress, and changes in muscle tone or level of consciousness. Diagnosis is typically confirmed through cranial ultrasound, computed tomography (CT), or magnetic resonance imaging (MRI). Treatment focuses on supportive care, maintaining oxygenation and circulation, controlling seizures, and monitoring for increased intracranial pressure. Transient tachypnea of the newborn TTN is a temporary respiratory condition caused by delayed clearance of fetal lung fluid after birth. It is one of the most common causes of respiratory distress in term and near-term newborns and is often seen after cesarean birth without labor because the infant does not experience the normal squeezing of fluid from the lungs during vaginal delivery. The primary sign is tachypnea, with respiratory rates often greater than 60 breaths per minute. Infants may also exhibit chest retractions, grunting, nasal flaring, and mild cyanosis. Symptoms usually begin within the first few hours after birth. TTN is generally a self-limiting condition that resolves as excess lung fluid is absorbed, usually within 24 to 72 hours. Treatment is supportive and may include oxygen therapy, monitoring of respiratory status and oxygen saturation, temperature regulation, and intravenous fluids if rapid breathing interferes with feeding. Meconium aspiration syndrome, MAS, occurs when a fetus or newborn inhales meconium-stained amniotic fluid into the lungs. Meconium is the infant's first stool and is normally passed after birth. However, fetal stress caused by hypoxia, asphyxia, cord compression, placental insufficiency, or postterm pregnancy may cause the fetus to pass meconium before delivery. If fetal distress leads to gasping respirations in utero, meconium-contaminated fluid can be drawn into the lungs. Once aspirated, meconium may obstruct airways, interfere with gas exchange, cause inflammation, and increase the risk of respiratory distress after birth. Newborns with MAS may exhibit tachypnea, grunting, retractions, nasal flaring, cyanosis, and decreased oxygen saturation. Lung sounds may be coarse, and the infant may require oxygen therapy, continuous positive airway pressure CPAP, mechanical ventilation, or other respiratory support depending on severity. Current neonatal resuscitation guidelines do not recommend routine suctioning of the mouth and nose for vigorous infants born through meconium-stained amniotic fluid. Instead, treatment focuses on assessment and respiratory support as needed. Neonatal abstinence syndrome (NAS) occurs when a newborn is exposed to certain substances, most commonly opioids, during pregnancy, and then experiences withdrawal after birth when exposure suddenly stops. Because many drugs cross the placenta, this can become physically dependent on the substance while in utero. Withdrawal symptoms may begin within hours to several days after birth and can include high-pitched crying, irritability, tremors, increased muscle tone, poor feeding, vomiting, diarrhea, sweating, sneezing, fever, and seizures in severe cases. Infants often have difficulty being consoled and may experience poor weight gain due to feeding difficulties and increased calorie expenditure. Treatment focuses on supportive care, including a quiet environment, swaddling, gentle handling, frequent feedings, and close monitoring. Some infants require medication therapy, such as morphine or methadone, which is gradually tapered to reduce withdrawal symptoms. Infants born to mothers with diabetes are exposed to higher than normal glucose levels during pregnancy because glucose crosses the placenta. As a result, the fetus develops hyperglycemia, which stimulates the fetal pancreas to produce large amounts of insulin. This excess insulin, known as fetal hyperinsulinism, acts as a growth hormone and promotes the storage of fat and protein. Consequently, these infants are often large for gestational age (LGA) and may develop macrosomia, typically defined as a birth weight greater than 4,500 grams, depending on the reference used. After birth, the maternal glucose supply is suddenly removed, but the infant continues to produce high levels of insulin. This places the newborn at risk for hypoglycemia, which is one of the most important complications nurses monitor during the first hours of life. Other potential complications include respiratory distress syndrome, polycythemia, hypocalcemia, hyperbilirubinemia, and birth injuries related to large size.